Good afternoon. My name is Dorothea Vafiadis. I'm the Director of Healthy Living for the American Heart Association. Thank you for the opportunity to present AHA's views. We have 5 points for consideration. First, as we've heard today, persuasive evidence from high-quality research supports the link between reducing sodium intake and improvements in blood pressure, as well as reduced risk for a number of chronic diseases. AHA supports lowering sodium's current adequate intake and tolerable upper intake level. The AI should support optimum reduction in blood pressure and chronic disease risk and be sufficient to meet dietary requirements for other essential nutrients. Updated food intake modeling should inform the latter, particularly in light of product renovations and sodium reductions in many foods available in the marketplace. Lowering sodium's DRI values is especially important for those who would benefit from blood pressure lowering. This includes middle-aged and older adults, African Americans, and individuals with diabetes, hypertension, or chronic kidney disease. These populations comprise the majority of U.S. adults. The sodium DRI values for children and adolescents should be extrapolated down from the adult values using relative energy intake. The committee's report and accompanying dissemination pieces should emphasize proper interpretation of the DRI values. It should be clear that an AI is assumed to ensure nutritional adequacy and that a UL is the highest tolerable intake level that is unlikely to pose risk of adverse health effects. It is not a recommended intake. Most in the public and many health professionals are not fully aware of this distinction. Second, we urge the committee to prioritize rigorous investigations and to appropriately weigh studies of lower quality. Methodological problems, such as unreliable measures of sodium intake, reverse causality, residual confounding, and inadequate follow-up limit a study's usefulness for guiding nutrition policy. Third, we urge the committee to consider health equity. Populations more sensitive to the blood pressure rising effects of excess sodium intake tend to be at a higher risk for cardiovascular diseases. We have relatively fewer data about sodium intake and health for U.S. Asian and Native American populations, but they may experience disproportionate risk of cardiovascular and other chronic diseases. Fourth, we suggest that the committee include language in its final report that emphasizes the recommendations for sodium and potassium intake in the context of the total diet. Current recommendations for these nutrients are not isolated, but occur in the context of guidance to choose healthy eating patterns. Fifth, and finally, we urge the committee to consider the potential impact DRIs will have on sodium levels in the food environment. Lowering these levels is an important element of a comprehensive, systematic approach to health promotion and disease prevention. Sodium added to food outside the home accounts for more than 2/3 of total sodium intake. AHA survey data indicate that 75% of Americans want less sodium in processed and restaurant foods. Less sodium in the food supply can improve and diversify consumer choice because salt can be added to food but cannot be taken out. On behalf of the American Heart Association, I'd like to thank the committee for its careful consideration of the evidence on this important topic, and thank you for the opportunity to present AHA's views today.